Dr. Woolfrey.
Good morning. Fundamental to family medicine is the doctor-patient relationship, and as my colleagues have illustrated for you today, this is a special relationship which develops over time. We get to know our patients in the context of their family, their community. We get to know them as friends, and in many ways it is a friendship. It takes time for this to develop, and within that trusted relationship, we are able to provide optimum care because we know so much about our patients through time. I have been a family physician in Botwood, which is a rural community, for the past 13 years, providing a broad spectrum of care, not just office-based practice, but palliative care, long-term care, and 24-hour, 7-day-per-week emergency service. We have a catchment area of 7,300 people in 13 different coastal communities, and all of this care is provided by 5 family physicians. Within that 13-year time span, I have had 23 colleagues, 23, which is a huge turnover. And this is not unique to Botwood. I would challenge you that this is happening within all coastal communities in this province in family medicine. People who are well take their bodies for granted, and they may not appreciate the importance of the doctor-patient relationship and having a trusted family physician. But imagine for a moment if one is sick with chronic disease, elderly. The family physician is the person who helps guide you through the complexity of the medical system, to arrange appointments with specialist colleagues, investigations, and other things. If one has had a long-term relationship with one's family physician, that process is much easier. Imagine having chronic illness and having your family physician change every year, or every 2 years, or every 3 to 6 months. This is a reality for all too many individuals in rural Newfoundland and Labrador today. It severely impacts the continuity of care which is provided, and I would argue that it probably has adverse outcome in the long run. This is especially important where in rural communities the population is aging rapidly. Over 25% of my practice is over the age of 65, and elderly individuals certainly have a more common prevalence of chronic illnesses such as type 2 diabetes, lung diseases, heart disease, etc. Turnover in rural Newfoundland, our recruitment today is almost entirely offshore, international medical graduates. We're certainly grateful that these individuals come to practice, but they tend to stay less than 2 years. Of the 23 that I've referred to, those who have left have gone to mainland Canada, with the exception of 2 who have moved here to St. John's. Canada is a rich nation, and one needs to question the practice of recruiting highly skilled physicians from nations such as Iraq, Libya, Nigeria, and other developing and struggling nations who can ill afford to lose these individuals. We have a wonderful medical school here, Memorial University, which produces world-class family physicians and specialist physicians, yet our ability to attract and retain these individuals in rural Newfoundland is severely hampered by present conditions. Offers of employment, the working conditions, and the general atmosphere and climate are simply more attractive in other jurisdictions. This is something which has to change so that we can retain our own well-trained individuals, so that long-term relationships can develop with patients, and ultimately improve the quality of care and the cost-effectiveness of care that we provide in this province.
Thank you, Dr. Woolfrey. We certainly at this time would entertain any questions that you might have for us.
Med students at MUN pay a lot more tuition than other students. Would lowering their tuition or some sort of extra debt relief for them help with your recruitment?
That's probably not really the right question for our group to handle. That's something that's probably better answered by the Dean. I mean, the issue of student debt you heard Dr. Callahan talk about is a very real one, and anything that can be done to alleviate that problem would certainly be looked upon favorably.
If each of you could tell me what you see as the biggest or the most realistic solution to your problem. What could be done to fix it all?
More doctors.
And what
Number
do you think?
one. I think access to technology is big too. So I think, you know, we have the technology, but I think there needs to be a closer look at how to better access the technology that we have, which obviously will involve more healthcare professionals being hired in order for us to access the technology. The number one thing, I think, is more physicians.
Yeah, and I think to follow on from that, I mean, you heard Dr. Graham say even, you know, other health professionals which would help our job would certainly be very important. I think one of the other things that our province suffers for is a huge lack of information technology resources. Many provinces now have electronic medical records that physicians use, have networking with the local hospitals so they can access information about the patient's diagnostics, their blood work results. We have none of that available in our province. Most physicians in our province still use paper records, and you know, there's a good recognition that paper records, while reasonable, you know, are not ideal when you're looking at the very complex chronic patients that you've heard us talk about, where you need to look back over 10 and 20 years worth of information, and EMR would certainly make that much more feasible, and we've certainly suggested that to government on a number of occasions.
Healthcare is about people, and we have to stabilize the system. Right now we have a system which is very reactive. It's not being proactive enough. It's not planning for the future. Day to day, as my colleagues have given examples, we are trying to do things on an urgent basis to the point that routine care is put to the wayside. Urgent has become almost the new normal, the new routine way of doing business. And any system which is destabilized in that manner is failed. It will fail in the long run. So there has to be a stabilization of the system, and that involves people, it involves technologies and other things.
Dr. Gray?
I believe we also need more organized systems. For instance, we talked a lot about wait times to see us and to see specialists. The referral patterns to see specialists are it's a big black box. It's, you know, some specialists you need a letter first, some contact us, some contact the patient, and it's not this is the way within this discipline or this is the way within this community. It's all over the place. Some patients, you know, wait a year to see a certain consultant and then get a call the day before that they have an appointment tomorrow, and they might be in a rural community and unable to get there that quickly and whatnot. So I think we need more standardized types of ways to refer to specialists and to have the communication back to us in a timely fashion. I believe, in all honesty, I could see at least half a dozen patients more a day if myself and my patient did not spend as much time talking about waiting. There are patients that I see very frequently. The only reason to see them is to touch base to see if them or if I have heard about their upcoming test or visit. Again, that's, you know, it's not a waste of that visit because that's very important to that patient. But wouldn't it be better if there was a better system?
And just to pick up, Barb, on Wendy's point, there are some really good models elsewhere in the country using things like single point of entry, where you know, every physician will refer to a central pool, and then it's kind of metered out depending on who's got the next available appointment and this kind of thing, and it's showing excellent improvement in wait times elsewhere in the country. So this is not things that haven't been looked at.